Let's go ahead and put on our clinical director hats today because we are auditing something that should honestly make every single doctor and healthcare administrator stop and pay attention. We're diving into this explainer to evaluate Google DeepMind's new AI co-clinician. And, well, spoiler alert here, this is absolutely not your average run-of-the-mill chatbot. We're talking about a breakthrough that goes way beyond text to actually see, hear, and guide patients. You know, for literally 70 years, the idea of a super intelligent medical AI was mostly just theory, something trapped in sci-fi or limited to static text prompts. But today, we're analyzing an agent that evaluates physical cues in real time. It's a true multimodal system. That means it's looking at the patient through a camera, it's listening to their voice, and it's actually guiding them through a physical exam. It analyzes movement, picks up on hesitation, and does it all with incredibly low latency. It is literally designed to see, hear, and guide.
So, to properly audit this tech, here's our roadmap. We'll start with real-time patient case studies, discuss the premature closure risk, look at benchmarking against existing AI, explore what it means to go beyond multiple-choice medicine, and finally, deliver the clinical director's verdict.
Okay, Section 1, Real-Time Patient Case Studies, Triage and Empathy. Let's kick off our clinical observation with a high-acuity case. In primary care, correctly triaging severe symptoms without causing a panic is basically the gold standard, right? So here, the system was tested with a patient presenting with really severe abdominal pain. What's wild here is how the AI mimics actual physical exam best practices. The patient complains of this intense burning near the belly button. But instead of jumping right to that spot, the AI asks the patient to palpate the actual belly button first, which didn't hurt, before asking them to press just above it in the epigastric region, which was the real source of the pain. It deliberately established a baseline away from the pain first. It even tested for rebound tenderness, asking, hey, does it hurt more when you press down or when you let go? Thinking about this from an administrative standpoint, I am thrilled to see it didn't just take a wild guess at the diagnosis. It correctly mapped out the exact triage steps a human doctor would order. It recognized the severity, the patient couldn't even keep water down, and immediately laid out a concrete, safe plan. It told the patient to get to the ER, correctly anticipating they'd need IV fluids, blood tests, and almost certainly a CT scan to figure out if it was appendicitis or pancreatitis. That is exactly the kind of safety protocol we need to see to prevent errors during high-acuity triage. Now let's look at how this builds into specialist care. In our second case, we have a physician role-playing a patient with an unevoked visual sign, specifically an eyelid droop. What's absolutely fascinating here is the AI's internal thought log. The system visually verified the droop, but, and this is key, it didn't just blurt it out and interrupt the patient. It actually waited until the patient complained about it. And only then did it log, I see the patient's eyelid is drooping. And this brilliantly illustrates not just clinical reasoning, but actual bedside manner. It asks targeted questions, like if the double vision gets worse later in the day, which is a huge differentiator for things like myasthenia gravis versus Lambert-Eaton syndrome. Then it had the patient look up at the ceiling for 30 seconds to test for muscle fatigue. That is not some generic cookie-cutter exam. That is a highly specific, tailored telehealth maneuver. After that, it compassionately reassured the patient and seamlessly established the guardrails to escalate the case to an in-person neurologist. Moving on to Section 2, the premature closure risk limitations in practice. Look, no clinical audit is complete without actively hunting for systemic risks. As impressive as those first two cases were, our third case study highlights a really critical diagnostic limitation, one that medical residents and veteran doctors alike need to be trained to spot. So here, the AI is observing a patient with a gradual shoulder overuse injury. Using its low-latency video, the AI actually catches the patient hesitating. It had given a multi-step instruction, lift forward, then to the side. When the patient only lifted forward, the AI noticed they missed a step and gently prompted them to do the side lift. That's an incredibly human interaction. It correctly gauged the acuity, suspected rotator cuff tendinitis, and made the right call to suggest conservative treatment like ice and rest, rather than rushing to order an MRI or surgery. But here is the catch. While the conservative treatment plan was completely safe, the clinical reasoning process fell short. The AI fell victim to what we in medicine call premature closure. It shows maybe 3 out of 8 possible physical exam tests, and then it just stopped. It totally missed the maneuvers needed to localize exactly where the impingement was. If we're designing a practical training curriculum for medical residents, this is exactly the core pitfall to highlight. You simply cannot let an AI's initial correct vibe stop you from completing a thorough manual examination. All right, Section 3, benchmarking data, the hard numbers. Now that we've seen how it practices and where its blind spots are, let's zoom out. How does this thing actually stack up statistically against existing healthcare benchmarks? DeepMind didn't just rely on good vibes. They put their model in front of real academic physicians for a blind head-to-head test. No marketing, no cherry picking. Evaluators compared the AI co-clinician against the existing clinician-facing tools that practices use today. And the results? Pretty definitive. 67% of the time, doctors preferred the new AI co-clinician, basically blowing the legacy tools out the water. But here's where it gets super interesting for us. They tested it against GPT 5.4, which we know is a massively powerful general model. The specialized AI co-clinician won 63-30. This was graded using a strict no-harm framework. It tested for errors of commission, like giving wrong facts, and errors of omission, like leaving out critical steps. Because in medicine, what you fail to say can literally be just as dangerous as what you do say. That specialized medical reasoning makes a huge difference. Astonishingly, out of 97 realistic primary care queries tested, the AI co-clinician recorded exactly 0 critical errors. Let me repeat that, 0. Hitting that near-perfect safety threshold without hallucinating dangerous advice is a benchmark that medical AI has historically struggled to even get close to. Section 4. Beyond multiple choice medicine. To truly understand why those safety numbers are such a big deal for a medical director, we need to look at how they were actually tested. Enter the RxQA benchmark, which takes us way beyond simple textbook multiple choice testing. Look, traditionally, most medical AI benchmarks rely on your classic A, B, C, D multiple choice questions. But as we all know, real-world medicine doesn't come with multiple choice options. It comes with a patient saying something like, "Hey, my mom's been on this pill for 10 years and now her ankles are swelling up. Is that bad?" The RxQA benchmark forces the AI to process those ambiguous, messy contexts exactly the way patients present them in real, open-ended consultations. Let's dig into what this benchmark actually tests. We're talking complex drug interactions, dosing edge cases, all based on raw, open FDA data. Historically, large language models just fall apart here because they're trained on the open web, which, let's be honest, is full of garbage in, garbage out medical advice. This AI dominated because it could synthesize highly technical pharmacological data and actually explain it conversationally without losing the clinical thread. Finally, Section 5, the clinical director's verdict. Let's wrap up this explainer by reviewing the ultimate administrative assessment. DeepMind teamed up with physicians from Harvard and Stanford to answer one question: could this system actually act like a doctor in a holistic way? These experts put together 20 synthetic clinical scenarios. They had real physicians role play as the patients, and they evaluated the AI across a staggering 140 distinct aspects of consultation skill. So we aren't just checking if it got the diagnosis right, we're grading bedside manner, professional empathy, reading visual symptoms, and seeing if it asks the right follow-up questions. And here is the headline metric. The AI matched or exceeded human primary care physicians in 68 of those 140 consultation areas, matching human doctors in basically half of all clinical consultation metrics. That is a massive leap for a multimodal system. It proves this tech can absolutely hold its own when it comes to evidence synthesis and establishing real patient rapport. However, as clinical directors, we always have to look at the other side of the ledger, right? Human doctors still firmly maintain the edge when it comes to catching the most dangerous, subtle red flags and overseeing those really intricate in-person physical exams. What this means is that if we're going to transition to AI-supported diagnostic consultations, human oversight is completely non-negotiable. We have to have strict safety protocols where human doctors override AI suggestions to prevent serious errors. And DeepMind's own conclusion actually aligns perfectly with a sound clinical audit. They state it very clearly. This is a supportive tool, not a replacement. It's a highly capable assistant. It can take thorough histories, synthesize complex drug data, even visually triage patients. But it absolutely requires a human in the loop to finalize diagnoses and execute the deeper physical maneuvers. So it's an incredible step forward for clinical care, for sure. But as we wrap up, it leaves us with one really provocative thought to ponder. If a brand new multimodal model is already matching human physicians in 68 out of 140 clinical skills today, exactly how long until that gap closes completely. Thanks so much for joining me on this explainer.